Welcome back to the Hot Flash Diaries podcast. This is officially episode 5, followed by episode 6 with the one and only Dr. Daiana Castleman. We're so excited to have her here on the podcast. Thank you for being here today.
Thank you so much, Jessica. I'm honored to be here.
So, Doctor, I'll give you a little rundown on who this lovely human is. She is a naturopathic doctor and a Menopause Society certified practitioner based in Oakville, Ontario. Dr. Castleman specializes in evidence-based care for women navigating the often confusing and overwhelming transitions through perimenopause and menopause. With a clinical focus on empowering women with knowledge and practical tools, she helps address everything from brain fog and sleep disruptions to mood swings and low libido, all while emphasizing long-term health and well-being. Her approach combines rigorous science with genuine compassion, informed both by her clinical expertise and the real-life experience of women in her own family. We are just so fortunate to have you here today. You are a wealth of knowledge. Thanks again.
Well, thank you. And for that lovely introduction.
Well, so just to give the listeners a little bit of a background, I had the pleasure of meeting Dr. Castleman at the Pleasure Principle in Hamilton that Kristen Parisi put together this spring. And I was blown away by your talk, your chat. I just sat there. I could have listened to you talk all day long. And I learned so much. Even as a practitioner myself, I thought, oh my goodness, I've just learned so many little pearls. And I knew that I had to chat with you and bring you on the podcast because your approach is so incredible. And I love how focused you are on prevention. That I think you said a few times, prevention is everything.
Mm-hmm.
And I really love that because I think a lot of times we don't know what to do to sort of advocate for ourselves and how to get to that point where we feel like we really can, take control of our health in a way that we make some changes moving forward and have, a really lovely, healthy life moving forward.
Mm-hmm.
And so that focus of being able to empower women to really make those, changes and decisions on their own, but with that support of having a healthcare provider in their circle that can advocate for them to, have a good longevity and just overall feel really, empowered with their care is what really stood out. So I really appreciate having you.
Thank you. I'm so glad that you enjoyed it. It was a great day for sure. There were so many amazing speakers that day at the conference. I always say when women are equipped with the right knowledge, they will make the best decisions for their health, right? And I think that's part of our role as clinicians is how do we equip them with the best information so that they can make those decisions for their health.
That's just it. And although, you were speaking to a room of practitioners, a variety of different specialties from pelvic floor physio to physicians to NPs to all the things, when I've had the opportunity of listening to some of your patient-focused messaging, what I love is that you are able to explain things in such a simple way that makes so much sense and is so impactful. And that's really what matters, is that patients can understand the information so that they can translate that into their own health and their own situation. Really, that's the only way we can make changes. So I just love that.
Try my best.
Yeah, well, you do great. And I'm so pleased. But we're going to actually record a 2-part episode where we're going to really focus in on cancer screening and prevention for women in midlife, really talking about what are the things we should really be looking after, what's important, and how we can get this type of screening onto the calendar or ticked off, if you will, as time goes on, really with a focus of looking after ourselves. So I'll let you sort of start off, if you don't mind, chatting about some of the breast cancer screening, because that guideline has just recently changed, not that long ago.
For the better?
For the better.
Yeah.
So tell us all about it.
Away for sure. Screening mammograms are now recommended to start at age 40 for average risk women. The previous starting age was age 50, so that is a really great improvement. Now, what I want to say about Canada, for any listeners who are in Canada, this is also very province dependent. So one of my favorite resources that I always like to recommend is dancebreastcanada.ca are able to they show it beautifully. They kind of list it by province and like when screening starts for each province. Can you self-refer or not self-refer? So again, maybe check based on your provincial screening guidelines because it can depend where you are. But in Ontario, which is where we both practice, the screening guideline has changed to age 40. And this was really a big step. This was a really important step for breast cancer screening because we had a lot of evidence that was demonstrating that if we are including women who are now 40 to 49, they had a significantly higher survival from breast cancer, right? Because a lot of women were being diagnosed with later stage breast cancer, much more aggressive cancers. And we were really missing these women. So this is a really, really positive change. And we are increasing breast cancer survival without increasing overdiagnosis or unnecessary biopsies, which is really important, right? It's
It
not,
is really.
yeah, sorry. Yeah, it's
No, I
not
was
like
going to
we're
say,
increasing any harm there, which is what I want to bring to the front. Yeah.
well, that's just it. I think a lot of the worry is around the density of the breast when we're younger. And will that
Mhm.
produce a lot of false negative or false positives rather in
Right.
screening? And then how does that translate into more testing that's maybe not necessary? But that
Exactly.
said, we want early detection so
Mhm.
that we can start treatment, if necessary, as soon as possible, so that long-term longevity is there. So,
Exactly. Yeah. And
yeah,
we do know that women who have mammograms are 40% less likely to die from breast cancer than those who do not have mammograms. Like they truly are life saving, and I'm just going to put this in there because I get asked this a lot as a naturopathic doctor. Thermography does not replace mammograms. And I'll just put
thank
a
you.
full stop on that. And we're just going to put a period there. And it just does not. So we need mammograms. They are the gold standard. And they, like I said, they do save lives. When you do go get your mammograms, you are going to have a report that comes back and it will tell you your breast density grade. So there are 4 grades, grade A, B, C, and D. And this is important for you to know and for, your doctor has that information as well. Grade C and D breast density, they are the denser breasts. They are associated with a higher risk of breast cancer. So again, really important that you have this information. Basically, when we have a mammogram that is done, dense tissue shows up as white. Cancer also shows up as white. So it's really hard to detect the cancer. It's like having white in a background of white. And so again, it's important that if you do have dense breasts, that you also will likely be recommended for supplemental screening. Now, if you have category D breast density, it is covered by OHIP to get supplemental screening done, meaning like an ultrasound or MRI. If you have category C breast density, you can request supplemental screening. So that might depend on other risk factors for you. But that supplemental screening is actually really, really important as well.
For sure. And just to give our listeners a bit of an understanding, because it does become quite medical, a lot of jargon
Yeah,
around the density and the classifications. But what's great is that the radiologists, the physicians that read the reports, always provide recommendations above and beyond.
correct.
So in my clinical experience, it's been fantastic. If you get a report back that has a questionable result, it's so well set up that really nothing falls through the cracks.
Hmm.
Thankfully, with any of my patients, I know it's not perfect, but that said, there's just a whole team standing by to get people booked in for the supplemental testing
Yes.
ASAP. So it's really quite a fantastic program. But yeah, it's
Hmm.
worthwhile to do for sure, and super exciting change in
Hmm.
Ontario.
Yeah. And another really important point, I get asked a lot about this too, is breast density can only be determined by mammogram. Okay. It's not by size or feel. Both fattier tissue and dense tissue can both feel like soft, firm, or lumpy. So, really important that we understand we're only going to know our breast density by doing the mammogram.
Exactly. Yeah. And it's very
Yeah.
subjective too, right? What might
Hmm.
feel lumpy to one person may not be lumpy to
Exactly.
another, right?
Yeah.
So that's amazing. Now, tell us about the IBIS risk
Hmm.
calculator, because I was so pumped that you too use this in your clinical
Hmm.
practice. It's not something that's really well known.
Yeah, it's such a great tool. So the IBIS, it's also called the Tyre-Kruzik calculator. It basically gives you both your 10-year risk as well as your lifetime risk of getting breast cancer. So when you do this calculator, you can do it, in office with your healthcare provider. It just takes a couple of minutes. It's going to ask things like, your age of your first menstrual period, where you are in your menopause journey. Are you premenopause, perimenopause, postmenopause, your breast density, if you do have that information, if you've had any genetic testing done, like if you've had prior biopsy of a breast. So it kind of takes all this really great information. Of course, family history I'll ask you about as well, and then give you this score. score, and it will compare it, of course, to the population average. Again, depending on where you are located in the US, they will say anything over 20% is considered high risk if you have over 20% lifetime risk. In Canada, the bar is set at 25%. I think actually Alberta is the only province where it's 20%. So again, it might differ where you are, but it gives you this lifetime risk score. And again, if you are part of that higher category, if you're deemed high risk, that is when we would be taking that into account. Again, that might mean we're usually offering maybe additional like MRI screening, right? We'll be doing additional testing. Maybe we're doing it also more frequently.
Exactly.
That is really how it guides us. And I know this calculator became really popular when Olivia Munn started really talking about it and how it really had saved, her from, because it prompted her to do additional screening, and that's when they found her cancer. So it is definitely a great tool. I use it with all of my patients, and it really doesn't take long to complete, like a couple of minutes.
No, for sure. And it's worthwhile doing even if you don't know your breast density. So I will include it in the show notes so that there's a link and you're able to complete it. And that might encourage some women that maybe haven't done their mammogram yet to go ahead and book that. And also in Ontario, just so that women are aware, you don't need a physician or a nurse practitioner requisition to be able to book your mammogram. You can actually book that yourself. Just give them a call and book it. So no need to wait in case your family doctor is backlogged. You can advocate for sure. Yeah.
Exactly.
And so with that, in terms of the frequency of screening, that really does depend on the individual, doesn't it?
Exactly. Yes. It'll depend on your individual risk factors, your breast density grade, right? For example, if you have grade D breast density, they'll tell you come back every year. So it really depends. If a woman is average risk, it'll likely be every 2 years. So again, that will be a conversation that you have with your healthcare provider.
Exactly. And again, the radiologist always lets us know as healthcare providers what to recommend. Sometimes it's every 2, sometimes 3. It really does depend on the person and age and all the factors involved. So that's fantastic. A really big step forward for women's health.
I think so.
Super excited.
It's amazing. And actually, sorry, the other thing that came up that I just wanted to mention, because this is another fantastic resource, is I really think is important for us as women to also really know our breasts. And I think self-breast exams are really, really important. There's a great, I don't know if you know of this tool. It's called knowyourlemons. Do you know of this app? Okay. It's a really, really great app. So it's called Know Your Lemons. It's a global breast health education initiative, and it was created by the nonprofit Worldwide Breast Cancer, and it was really designed to actually improve early detection and by teaching people how to recognize signs and symptoms of breast cancer. And it walks through 12 signs of breast cancer, and it basically uses these training videos, and they use lemons to kind of guide that teaching. So I really, really love it. I recommend it to my patients. So I just wanted to let you know as well in your audience, knowyourlemons.org is a great way to kind of get familiar with doing self-breast exams.
Perfect. And we'll include that one too. And I'm going to check it out today because now I'm intrigued. That's so great. I'm all for websites and apps that are helpful, that really promote evidence-based information, less so with all the stuff that happens online and Facebook. More about the good websites. So let's push those forward for sure. Another huge step forward for women has been the changes in the cervical cancer screening guidelines as well. So our women know it as our pap smears, right? So tell us how that's changed recently.
So yes, in Ontario, as of March of this year, March 2025, we've introduced HPV testing. And so as you've mentioned, what we used to have was something called pap smears. And really the difference here is that an HPV test tests directly for the presence of high-risk HPV DNA. So HPV stands for human papillomavirus. It is the most common cause of cervical cancer. It pretty much accounts for almost all cases. And with HPV testing, we typically start around age 25. So really the big step forward here is that HPV testing does have higher sensitivity, which means it's better at detecting cervical precancer or cancer than what we had with pap smears. So we see it to be much more accurate in detecting those early changes. So it's going to look for those high-risk HPV DNA. And with pap testing, the difference is that pap test was really looking at abnormal cell changes in the cervix that may indicate cancer or precancer. So now we're actually
Right.
able to look at the high risk HPV DNA. So if you, let's say, get a negative HPV results, that means that you don't have the oncogenic or cancer causing types of HPV. That's what
Right.
that test result lets us know. And so the other thing that changed was really the screening intervals here, because with HPV testing, you can do that every 5 years now. Now, if you are, for example, immunocompromised, it's every 3 years, right? So there is some, caveats there. If, let's say, HPV is not available for you, then pap smears is still every 3 years.
Right. So that's fantastic. I'm honestly so shocked that we did not test for HPV unless it was paid out of pocket privately by the patient for so many years. It makes perfect sense, doesn't it? I mean, as opposed to just looking at the changes in cells and
Yes.
then moving forward from there, we're really just tackling it head on. And it's been such an exciting change. So with the interval as well, hearing that if you have a negative result, you're good for 5 years, that's also encouraging because let's be honest, it's one of the least comfortable tests that we have to go
For
through as
sure.
women.
For
Yeah.
sure. And I think the important thing too is that even if you've been vaccinated against HPV, so if let's say you've had the Gardasil vaccine, you still need to continue screening as well. That's still important.
For sure. Yeah.
Yeah.
Yeah. That's really important. And that's a good point because I think sometimes people forget that
Mhm.
vaccines doesn't mean that you're not going to potentially be exposed or get, right, the virus. So important to have that checked. Yeah. It's been such an exciting change that, again, another giant step forward for us. So good to women's
Yes.
health.
Yes.
Now, let's talk about colorectal screening. So, colonoscopies and screening for colon cancer, because that's one that I don't think we talk about enough when it comes to women's health. I think we're really great
Very
at
true.
chatting about our gynecological, our female differences in comparison to men when it comes to cancer screening, but really we don't talk about colon cancer. And it's a significant issue in our society, right? Like it's very common. So tell us about what the guidelines are around that.
Yeah, so the newer Canadian guidelines now recommend that we're starting screening earlier at age 45. And that actually is because colorectal cancer is being found more often in younger adults. So sadly, that is the case. There is also a test called a FIT test, which stands for fecal immunochemical test. So I want to distinguish between that and then doing a colonoscopy. So the FIT test is a stool test that is actually done at home. It looks basically for hidden blood in your stool, which can be a sign of cancer or polyps. It's typically done about every 2 years. And then we also, of course, have the colonoscopy, which many people know about. I know no one loves the preparation for doing a colonoscopy, but it is a really great test that is definitely looking at, it's a great tool that we have for detecting colon cancer. It's usually done every 10 years for people that are average risk. Of course, if you are higher risk, you might be doing it more often. Sometimes, I get asked, like, which one do I do? Do I do the FIT test? Do I do colonoscopy? Again, this is going to be a very individualized decision. I do know FIT test, I've seen it in my practice, typically has higher participation from people. And I think, it is effective for reducing colorectal cancer mortality and incidence. So it definitely is a patient preference, resource availability as well, depending on where you live. But it is important that you are engaging in at least one of these tests that we have for detecting colon cancer. And then there are other risk factors as well that sometimes we look at to screen someone, maybe potentially earlier. Looking at, like, if you've had a personal history of colorectal polyps, if you have a personal history of a family inflammatory bowel disease, that's something to look into. Unexplained iron deficiency anemia, right? Like if we cannot explain like why you are anemic. So sometimes if we have also family history, so if you've had a first degree relative, so like a parent, sibling, child who had colorectal cancer, then you should start screening at either age 40 or 10 years before your relative was diagnosed, whichever one comes first. So again, if you have a family history or other risk factors, you do not have to wait until age 45 to start screening.
Yes, exactly. And you're right. There is more of an uptake with the FIT test. Again, just speaking from my family practice experience, the idea of doing a test at home, it's actually mailed to you. And when you get the test, you do it at home and mail it off. So nobody has to know. And it's a very private sort of experience, whereas the colonoscopy is a process. It's a couple day experience because you have to go through the prep and so forth, but they are different. And as you've explained, it's really important to understand what your risk is as far as what's best. So if there's any family history at all of colon cancer, I bypass the FIT entirely and highly recommend the colonoscopy, unless of course somebody's resistant, but that's very, very rare.
Yeah.
They usually will accept the advice and gladly go for their colonoscopy. But and this too is interesting because much like the mammogram, when the gastroenterologists or general surgeons that do the colonoscopy send the reports back, they really are great at giving guidelines as far as when the next screening should be done. So really, really great. The only sort of pearl I will throw out there is to encourage you to keep track of dates, because time goes by so fast. And so if there's some sort of tracker you can put on your computer or your phone to say, okay, I'm due for my colonoscopy, let's say in August of 2026, maybe I should nudge my family doctor January, February, because the reality is that referrals have to go out and they take a while to get in. So the quicker we can get that referral off, the quicker you will get in queue for the time that you're due. So really advocating for yourself is huge here.
That's a great pearl. I was just thinking as you were saying that, like, I always have a hard time remembering, like, when did I do my last PAP or things like that. Even it's to your point, it's very hard to actually remember those dates. But for something where you need that referral and you're waiting, it's such a great pearl for sure.
It is. And I actually will put it in my calendar. My partner John will laugh because when we first met, I used a paper calendar and I was resistant to using anything digital that way. And now I'm a diehard electronic calendar and I put everything in there with an alarm so that it tells me, okay, now I need to call. And sometimes I'll actually, again, welcome to perimenopause and your memory is not the greatest. I will put in little buffers where maybe a week later, I'll say, did you do this? Reminding you of
that.
X. Yeah. And so, I mean, things still fall through the cracks. I'm not perfect by any means, but yeah, I've learned to work with some limitations and it's working out really well. So just a suggestion.
I love that.
Yeah. And so above and beyond the cancer screening, one thing that I am big on is labs. Blood work assessment that really every 1 to 2 years, again, depending on risk and age and lifestyle and all that stuff. But tell me about what your thoughts are on and what should be included in a lab panel, whether it's every year or every couple of years.
Well, I love talking about cholesterol. So
I know.
That is definitely part of the panel. So yeah, I mean, there's definitely a few key things I would include in there. Things that stand out from a metabolic health perspective for sure is looking at your blood sugars and doing your diabetes screen, also looking at cholesterol. Now, we'll dive into each of these, but one of the things I really want to highlight is oftentimes when I am looking at blood work, one of the biggest things I highlight is I'm looking at trends. So this is really important and why when you look at for example, cholesterol guidelines, they're actually recommending that for people age 40 to 75 to actually do their cholesterol screening every 5 years, which I think you and I are doing it more often than that.
Sure.
I think every 5 years is a little bit too long to wait in between. Right. One thing that I'm always paying attention to is what has it been a year or two ago? What is it now? Like, what is the trend going towards? Because we definitely can see increases over time. And we can catch those increases if we're doing it more often, right? If you're doing it, let's say even every 2 years, if I'll talk about some numbers, but let's say your HbA1c, always used to be 5. And now this is a diabetes screening marker that we use. And now it's 5.2 and then it went to 5.3 and then it's 5.6. Like you're catching these trends early when you're doing blood work more often. And that's when you can take a preventative approach versus if it's been 5 or 10 years, like we're not catching these upward trends. So that's just one thing I really want to highlight as kind of like maybe a clinical pearl is that I really am a fan of my patients having access to their blood work results, so getting a copy of their results because I really want them to be in the driver's seat of knowing how to interpret their blood test. I show them exactly what to look for. And then, let's say every year, every 2 years, whenever they're getting their blood work, they know what trends to look for. I think that is when you start to really take agency in your health.
Yeah, that's honestly such a great point. I'm going to start doing that. I'm going to start encouraging my patients to, as most people will go to Life Labs, and they
Yes.
have a
Yep.
great app that you
They
can
do.
see
Yep.
your labs. And
Yep.
in fact, I think there's a trend button on there as well that you can
Awesome.
compare.
I actually didn't
I'm
know
pretty
that. Okay.
sure.
Yeah.
But it is fantastic. So that's great. That's a great idea. But you're right. If you can see those, what seems very small little
Yes.
increases over time, and there is a trend there, that's when you can really sort of attack the problem, right? Tackle the
Hmm.
problem as opposed to waiting. And likewise, it's really motivating to see it trend in the correct way
Exactly.
as you're making changes. So it can be
Yes.
really rewarding,
Exactly.
especially things like cholesterol that don't change overnight, right? It's something
Hmm.
that takes 3, sometimes 6, sometimes 9 months to adjust with lifestyle changes. So to be able to see those tangible changes
Yes.
on numbers, and I'm big into that. I love that. I love graphs.
Yes. Yeah.
The nerdy
Yeah.
side of me, I'm sure you can understand that. So yeah, that's a great approach.
Yeah. So, yeah, definitely cholesterol would be one thing we pay attention to. We know it's incredibly important. A lot of women are aware that it is the leading cause of death in women, heart diseases, postmenopause. And so cholesterol is definitely a really large contributor to that. And so we need to pay attention. And actually, around the time of menopause, as our estrogen declines, we can see an increase in cholesterol levels by up to 15%. So, again, it doesn't mean it increases 15% for every woman, of course, because we do have variation there, but that can still be a significant increase without changing anything, right? I'll always have patients say to
Absolutely.
me, I've done nothing different. I'm eating the same, I'm exercising, I'm doing all the
Yeah.
things, and we still see increases. So you want to catch it as this is happening. And that's why, to me, when we're talking about like a midlife health assessment, as you just approached it that way, which I really, really like, we have to be looking at doing these screenings more frequently so that we're catching these trends. So when you typically get as part of like a cholesterol panel, one other thing I wanted to bring up is that sometimes we take those scores and we put it also into risk calculators. So we can
Yes.
calculate your 10-year risk, for example, of getting a cardiovascular event. And so the one calculator that we have in Canada, it's called a Framingham Risk Calculator. So I'll ask again, your age, your sex, your total cholesterol levels, your systolic blood pressure. Are you a smoker? Do you have diabetes, family history of premature heart disease? And so you put all this into the calculator and it will tell your 10-year risk. Now, the biggest thing to know about this calculator is that it will fail to identify younger women who could really benefit from early prevention because these risk scores are really driven by age, right? So if you put 40, 45, 50, even 55, it will say in 10 years, your cardiovascular risk is still low. Why? Because it takes decades for cardiovascular
Yes.
disease to develop, right? It's like, to your point, it's not happening overnight. And so I think this is really, really, really important to know. It's not that we shouldn't be using these calculators, but it's understanding the limitations of these calculators and not basing our entire treatment decisions based on the fact that the calculator said you're low risk, right? Because if you do have elevated cholesterol, that still needs to be addressed, right? We want to be addressing it and not leaving it high. So that's just something I really want to highlight is look at these tools that we have, which are great, but then making sure we're stepping in for that early prevention, I think is a really big part of this.
Well, and especially with cholesterol, it's not just about heart health. It's also
Mm-hmm.
about brain health, right? It's really full
Exactly.
body. So it's really important. And again, to your point that it's one of the leading causes, it is the leading cause of death in women, sort of postmenopausal. So we
Mm-hmm.
really, we're all afraid of breast cancer, and rightfully so. But this
Mm-hmm.
truly is the killer, right? So we want to make sure we stay on top of it. And if we could, if we can nip it early, why wouldn't we? So
Exactly. Yeah.
fantastic. Can you tell us a little bit about the 2 other cholesterol markers above and beyond your typical lipid panel that are beneficial and why?
Definitely. So are you referring to lipoprotein A?
Yes.
Okay. So lipoprotein A is another type of cholesterol molecule that we have that is over 90% genetically determined. So it is something that it's a blood work test that you can ask your doctor for this test. And because it is largely genetically determined. It is not often influenced by the, lifestyle changes that we make. So again, the eating healthy and exercise and all those pieces. So it's a really important marker. It is an independent risk factor for cardiovascular disease, and it can definitely increase someone's risk if they do have it elevated. So
Right.
it is something that the Canadian Cardiovascular Society recommends that you do once in your lifetime, so you don't have to repeat this test. Over the age of 40, it's recommended to do it once. So you can add as part of your screening. If you're low, great. That's good to know. And about actually 1 in 5 people have it elevated. So about 20% of the population, which is not insignificant, right?
No.
That is, it's important to know, like I said, because then in those situations, if someone has elevated lipoprotein A, then in those situations, we probably want your LDL cholesterol, the cholesterol and your total cholesterol to be even lower
Right.
because you have this additional risk factor. So it does play into what your numbers or what our targets, right, for your numbers might be.
Amazing. And to your point, it's only one test, one time. It's not something
Exactly.
that has to be
Yeah.
repeated.
Yeah.
So it's fantastic and really does give us insight on some potential genetic,
Hmm.
changes that are going to contribute to your cardiovascular health. So fantastic thing to advocate for. And then there's also the ApoB.
Yes. I guess to talk about ApoB, I think it helps to talk a little bit about what LDL cholesterol is, because I think we just mentioned it, but just to explain a little bit. When we say LDL cholesterol, which is what shows up on your lipid panel on your blood work, LDL stands for low density lipoprotein. So it is a type of particle that basically carries cholesterol through your bloodstream. And I like to explain of it as these balls that are floating around. And the LDL cholesterol that you see on your lipid panel, it is basically the amount of cholesterol that is found inside of these balls. Okay, so it's like an estimate of the risk from that perspective. And these balls that are being carried around in the bloodstream, they have a protein attached to them. And each ball only has one single protein attached to it. And that protein is ApoB, which stands for apolipoprotein B. And so when we think about these two markers, LDL cholesterol and ApoB, ApoB is basically telling us how many balls do we have floating around in the bloodstream? So if we kind of use that highway analogy, which I like to use, ApoB is looking like how many cars do we have on the highway? And then LDL cholesterol is how many passengers are in
Right.
each of these cars.
I
So
love that.
ApoB, yeah. So ApoB is a great marker. It's again blood test that you can do, and it's going to help us look at the overall picture of what is happening. Now, about 90% of the ApoB particles are LDL cholesterol, so it makes up a large majority of them. But there are these types of balls that have ApoB attached to them. So like I said, ApoB can be more elevated because it's also found on other parts. So it is a little bit more accurate. It's
Amazing.
telling us the totality of like how many of these bad cholesterol essentially molecules do we have floating around. And again, I always like to highlight that cholesterol is not inherently bad. Of course, it is important for us, and it's important for many different processes in our body. It's about having elevated amounts over a long period of time. That's what's going to contribute to atherosclerosis or that plaque buildup in the arteries, right? So it's going to take
Exactly.
time to develop that. But it's when it's above a certain level for a long period of time, that's why we're just really looking at treating it and making sure that it's not going to get to a stage where there is a large probability of these plaques, these fatty deposits that are building up within our arteries.
Exactly. And I love that. And again, it's all based on risk and personal assessment, right?
Hmm.
That's why there is no such thing as a cookie cutter approach in any of this, because
Hmm.
each individual is so different. And I think what's really important to explain around the plaques is that the plaques really cause what's called atherosclerosis, which is the firming or the hardening of the arteries. And that the reason that that's important is that arteries should be very movable
Yes.
and bendy, if you will. I don't know if that's really a word. But what ends up happening with these plaques is that they basically line the inside of the vessel and
Hmm.
cause it to be hard. And if that was ever to be broken or bent and the plaques break off, that's what leads to heart attacks and strokes. So that's what we're really trying to avoid, notwithstanding some of that inflammatory process that happens when then our little vessels are trying to heal themselves, right? Because our bodies are so smart and really wanting to heal. So there's so many important aspects to cholesterol and lipids. It's not just about the lipid or the cholesterol
For sure.
in and of itself. There's so much more to it. But
And that's what I was actually just going to say, is that when you think about atherosclerotic cardiovascular disease, which is just cardiovascular disease that's due to this atherosclerosis, it's a complex process, right?
Totally.
LDL cholesterol doesn't explain the whole process, but it's an important contributor to it, right?
Exactly.
And I think, and what I see in my practice is that we just don't do, I think, a good enough job at catching it early and explaining why it is important to catch it early, right? We could be sitting at these borderline high levels where it's like, okay, it's high, but it's not that bad yet. And that's
Right.
what I really want to encourage my patients to not be in that state of it's not that bad yet, right? Because that is when, to your point, like that atherosclerosis, those plaques can start to really develop and cause more harm, right? So that's why when we're talking about prevention, why this conversation is so important, because catching things early is prevention, right? It's
For sure.
doing something before it ever becomes a really big problem.
Well, and you don't know when yet will be. Will that be next week? Will that be in 3 months or 3 years? Like, we have no idea. We don't have a crystal ball. So it's really about being mindful of that for sure. And now the ApoB, how often do you check that typically?
I will do it when I am doing the lipid panel for my patients. Yeah.
Yeah. So each time, for instance, if you start them on medication in 3 to 6 months, you would check it again.
Yeah.
Okay. Amazing.
Yeah.
Yeah. Interesting. I haven't been checking it that often, but I will likely change my practice because I think it does provide a more accurate picture of what's going on.
Yeah.
So there you go. So we definitely a cholesterol panel, lipid panel, and the addition of these 2 additional tests will give a lot more insight on what's going on from a cholesterol standpoint. The diabetes screen, which is the hemoglobin A1C, is really great. It's actually a fantastic value because in the past, we only had a fasting glucose or fasting sugar level to go off of to diagnose a diabetes. But this is actually a 3-month picture of what's happening with the sugar levels. And so it's really a fantastic gold standard percentage that gives us an idea of risk as well. Not just, do you have diabetes? Do you not?
Exactly.
It's where do you fall in that category? So that's really wonderful. What else do you like to throw in on a yearly or every 2-year panel?
So because I work with a large population of women in perimenopause, menopause, I mean, iron deficiency is so common in perimenopause. So definitely checking in on that. Vitamin D is really important. Vitamin B12. So from a nutrient perspective, I would say like those are the 3 really important ones to run. I do like to look at liver enzymes as well. I think those are important markers as well. And CRP. So C-reactive protein is an inflammation marker. Now it is a general inflammation marker, right? So it's not necessarily telling us where that inflammation is, but there's actually more and more research coming out now that is looking at CRP as also the marker for cardiovascular disease, right? And so that is really fascinating to me. I think we're going to be seeing it potentially maybe one day being used more as part of like our screening assessment tools that we have. But I think it is a great marker to know as well. And I typically like to add that one as well.
I love CRP. Any patient that I've seen from a midlife standpoint knows that I check a CRP, and I always explain it as the really, really sensitive blood test that will detect any sort of inflammation, but not so smart because it doesn't tell us exactly where the inflammation is, but at least it tells us. Yeah, exactly. Yeah. It's just one piece of the puzzle. So I do love that.
Now, before I forget, blood pressure screens are also incredibly important. Please check your blood pressure. If there's anything I actually always recommend for my patients, many of my patients do not have blood pressure monitors at home. So I'm always encouraging them to have a Hypertension Canada approved device at home. It is a great investment in your health to be checking this, not just maybe once every 3 years or something. If you're getting, a physical done every 3 years, like important that you really are checking this more frequently than that.
For sure. And I would say one little pearl with the blood pressure testing is I usually ask patients to pick a time when they are most relaxed. If you just had an interaction with your teenager, not a good time to check your blood pressure, or you just drove in traffic and you walk in the door, don't do it then. Do it in a time that you're relaxed and
early morning, typically best before coffee.
yeah, exactly. And I recommend generally doing 3 readings, sort of 5-ish minutes apart. And don't even look at the first reading because inevitably it's going to be high. And especially if you're trying to tell yourself to relax, it's going to be high. Second and third are generally the more accurate ones.
Yeah, that's exactly what I say. Those are great tips.
Oh, perfect. Can you tell us what ranges people should be focusing in on for their blood pressure?
For sure. So that's systolic, which is the top number. I like to see under 130. So if it's over 130, it is considered stage 1 hypertension if you're in the 130 to 139. And yes, you are at risk if it's over 120. So, over 120 to 129. And then the diastolic, you want to see under 90. Sorry, the bottom number, the diastolic under 90. And then again, it's at risk if it's like between 80 to 90. So you want it to be like 120 over 90 is like the typical number that we hear for sure. But I do get concerned when the systolic, the top number is over the 130 for sure. Like when they're already in stage 1 hypertension, I feel sometimes there's still a little bit of relaxation around oh, it's just like 135, it's not that bad. And no, like we really need to be looking at that. The really good thing about blood pressure is that it is so responsive as well to lifestyle changes, which is amazing. So of course we have medications, which are great tools, but also if we focus on exercise, all sorts of exercise helps to decrease blood pressure. If we focus on our nutrition, on stress management, alcohol consumption, reducing that, like all of those things really are like our blood pressure responds so well to those changes. So there's so many things we can do there.
Absolutely. Yeah. And again, not something that you have to do all the time, but even if you can check your blood pressure, even, once every couple of months is better than not at all. And in the days of Amazon, you can get a very reasonably priced approved cuff online that gets delivered, or you can also go to the pharmacy and the pharmacist can recommend one.
Exactly.
So I usually suggest that. I'm not a big fan. I don't know how you feel about the wrist cuffs. I think
no, it has to be an arm cuff. Yes.
Arm cuff. Yeah.
Wrist cuffs are not accurate. No. No,
yeah. And it's also the positions are hard to, people don't really know where to put them. So a regular old fashioned, cuff is what you want to do. Yeah. Amazing. And so before we wrap up this episode, can you give our listener a little bit of advice around how to sort of self-advocate if they have a provider who maybe is resistant to, ordering specific lab tests or, perhaps isn't as well-versed in the guidelines and they're resistant to ordering some of this? What is your recommendation around that?
Yeah, this is a really great question. There's a few different approaches, and I love to actually hear your tips as well on this. One is that I think it is important to let, the office know ahead of time that if you are wanting to focus on a prevention conversation, to let the doctor know, because you do want to have more time allotted to this conversation. And so I think giving, reception, like the admin team, a heads up to say, I want to come in and talk to my family doctor about XYZ, that will prompt them, and at least it will help your doctor prepare for that conversation as well. I think that's tip number 1 I really have, because again, it's really difficult to have these conversations in really quick, 7-minute on average appointments, right? And I do think a lot of doctors are really happy to share in this discussion, if they, are prepared and have the time too. So that's, I think, tip number 1 that I have. If number 2, for example, you are advocating for certain things to be tested, or maybe more frequent testing, and, maybe your doctor isn't as responsive to this, I think it actually does really help to bring, for example, guidelines, to your doctor. For example, if you look at the like dyslipidemia guidelines, like around cholesterol, they have what's called a pocket guide. So it's like a really great summary, that you can, like, for example, bring to your appointment and talk to your doctor about it and say, I've been doing my own reading. This is what I've seen. Like, I've listed here Lipoprotein A is like a test to be done, after the age of 40. Can we talk about this? Because this is where I've seen it. So I can help as well, is bringing that to your appointment.
That's amazing. I generally tend to ask or suggest, I should say, that patients write down what it is that they want to get done in their appointment, if you will, like a checklist. There are so many screening tests that we talked about today. For example, your mammogram, you don't need a referral, so you can self-refer. Even the FIT testing for the colon or colorectal cancer screening, and even blood work. If you let the staff know that, look, this is what I'm interested in doing, oftentimes, while you should still have an appointment to talk about your specific situation and risk, a lot of this stuff can be ordered in the back end and it takes a matter of seconds. So really, I encourage people to have a list because sometimes you get flustered. You're in there, you have a few questions, and a lot of practices have limitations on time, and also you're only able to ask 2 things, right? So I think if you set the tone, that's a great pearl and great advice. In terms of what you're wanting to accomplish in the appointment, it's fantastic. But then also just being very direct as far as this is my concern, and this is why I would prefer a colonoscopy versus the FIT test, for example.
Yes.
And I think you'd be hard pressed to find a nurse practitioner or a physician who would say, I'm not going to order, a colonoscopy for you. This is not what you need. If you're expressing concern, I think we all, really, well, we all have an oath or took an oath to do no harm and that we want to protect. So I think that it's, as long as you're advocating with reasonable information, I think sometimes there could be some challenges if we're bringing in misinformation, which unfortunately the internet is just full of.
And that does happen too, for sure. Yeah.
It does. Yeah. And it's, maybe the last appointment of the day, and sometimes people are exhausted. And so maybe it doesn't come across great. But at the end of the day, I think we just want the best for our patients. So having a little list and really advocating with, this is why I would really like this done, is great. And truly, if you come across somebody who's resistant, there's other ways. There's walk-in clinics and there's different approaches if you have no one else to turn to. But we would hope that wouldn't be the case.
Yes. Hopefully that's not the case. Yeah.
Amazing. Well, thank you so much. We are going to wrap up this episode. And in our next episode, we're going to chat about what can we do with all of the testing that we just chatted about if something were to be abnormal, in particular when we're talking about our labs. And what does that look like in terms of taking medication, and really trying to set the tone that medication is used as an adjunct. This is not, a failure, and certainly not a replacement for lifestyle changes. So I'm really excited to chat with you about that, in particular as it pertains to cholesterol, because I know that you're just the cholesterol queen. So thank you again for this recording this amazing episode with me, and we'll be back shortly with the next episode.
See you in the next one.
Thank you.